Hi everyone, this is John and my partner Miss Thảo, and today our team is talking about the new topic: the risk of acute myocardial infarction with NSAIDs in real-world use, based on meta-analysis of individual patient data. As you know, NSAIDs are among the most widely prescribed drugs in modern medicine. NSAIDs are effective in relieving pain, fever, and inflammation. Intravenous stimuli induced in bone cells to release arachidonic acids. The two general pathways by which arachidonic acids is broken down in the body are referred to as the COX pathway and the glycooxygenase pathway. The COX pathway eventually produced prostaglandins that leads to your symptoms like fever, pain, and inflammation. And NSAIDs plays a role in inhibiting the COX pathway, thus reducing prostaglandin production. This illustration shows the NSAIDs are classified according to their mechanism of action. Non-selective NSAIDs like ibuprofen, naproxen inhibit COX-1 and COX-2 enzymes. COX-2 selective like celecoxib, brivcoxib target only the COX-2 pathway. COX-1 is a constitutive member of normal cells. It appears anywhere in the body, whereas COX-2 is typically active at the site of inflammation. That's why NSAIDs has lots of side effects. The main mechanism is that the reactive oxygen species are generated, causes the apoptosis, is the programmed cell's death and oxidative stress. Those all lead to various cardiac conditions like acute myocardial infarction, heart failure. In the previous studies, they've been of limited use for assessing these rare adverse events. They have no clear conclusion about the timing of risk, the dose, duration, and the comparative risk between NSAIDs are poorly understood. Talking about the methods, they showed Medline, Embase, and PubMed by applying filters for retrieval of observational studies. They also retrieve systematic reviews of non-randomized studies of cardiovascular adverse events associated with NSAIDs. After initial search, they set up weekly updates from June 2010 to November 2013. About the study selection. Firstly, they selected studies documented acute myocardial infarction separately from other cardiovascular outcomes. Then they checked whether it's suitable for characterizing the time course, the dose, and duration effects of NSAIDs or not. The pooled study based on 446,763 patients included AR, MQ, Finland, GBRD, and Saskatchewan. Talking about statistics, the data of IDB meta-analysis were gathered at two levels. The higher level are about characteristics of 4 studies, and the lower one are individual patient characteristics. They opted for a one-stage modeling the patient framework, combining prior information with the available data, yields a posterior probability distribution for each parameter of interest. For the primary analysis, the between-study standard deviation on the log odds ratio, TAF, was assigned a half prior distribution. As a result, this study shows a clear perspective about the comparison between all drugs, the dose effects, the effect of duration of current use, and the recency of use. In the forest plots on the left side, present the posterior probability of existing certain risk threshold for each NZ of current use. As you can see, during the time, the risk of myocardial infection goes down. You can see by the lower position of lavender line for the low dose greater than 30 days and the blue line for the high dose greater than 30 days. The probability of increased risk of myocardial infection is also related to the high daily dose of using it, which can be illustrated by the high position of the red and yellow lines in the graphic axis. You can see that the red and the yellow line occupy the high position during the time. The plots on the right side in this figure present the summary adjustment odds ratio of acute myocardial infection by each drug. You can see that the odds ratios of acute myocardial infection for current use of ibuprofen possible increase 75%, and the odds ratios of acute myocardial infection of prophylaxis increased more than 100%. This table shows the probability of increased risk of myocardial infection with current use, dose level, and duration. You can see that the probability of increased risk of myocardial infection associated with NSAIDs for the first 2 to 7 days is about 92%, no, 92% to 99%. It means the risk of acute myocardial infection associated with NSAIDs use increased immediately when exposure. As a result, this study shows that the current use of all study NSAIDs, including naproxen, was associated with an increased risk of acute myocardial infection. And the patient approach found that greater than 90% probability of myocardial infection risk increased. The risk of myocardial infection with prophylaxis was greater than other NSAIDs. And the onset of risk of acute myocardial infection occurred in the first week and was greatest in the first month of treatment with higher dose. For discussion of the strengths and weaknesses of the study are about this study was drawn on a large population with an innovative application of IPD meta-analysis. The patient approach is useful for making decisions because in these methods, they use 95% credible interval instead of confident interval. Thus, they didn't represent uncertainty through repetition of the experience. And the confounders are unlikely to affect the substantive conclusion of this IPD meta-analysis. About the weaknesses of the study is the limitation of phone study is that the drug dispensing or drug prescribing doesn't match the drug intake, particularly the ibuprofen is one of the most common over-the-counter drugs, and it also needs to the data. And to compare with the other studies, this study mentioned about 3 other studies, but we just mentioned 2 of them. The first one is the precision. This study concluded that celecoxib was non-inferior to ibuprofen or naproxen for cardiovascular safety, similar to IDB meta-analysis. The precision trial shows evidence to suggest that naproxen isn't safer than other NSAIDs. And about the safety of non-steroidal anti-inflammatory SOS shows that the risk of acute myocardial infection are overall lower than those of this IDB meta-analysis. For conclusion, all NSAIDs, including naproxen, were found to be associated with an increased risk of acute myocardial infection. So, how to take NSAIDs safely? In clinical, to take NSAIDs safely, the first thing you have to estimate patient's baseline risk. And then we have to consider that disease have the alternative therapy or not. If not, we have to choose the NSAIDs like the first choice. We have to start with the lowest dose in the short term. And then we have to discuss with the patient about the side effects of the NSAID during the time they used. That's all. Thanks for your attention.